Buenos días, un viernes más y bienvenidos a las sesiones científicas del Servicio de Cardiología. Yo soy el doctor Ignacio Ferreira, jefe de Servicio de Cardiología, y hoy tenemos una sesión un tanto especial por dos motivos. Uno por la temática, que es una temática yo creo que es bastante novedosa y original sobre neuroablación, y porque es de esta jornada anual, pues es la primera sesión en la que pues, presenta un autor de fuera, en concreto el profesor Aksu del Hospital de Kocaeli de Turquía, y que nos hablará de neuroablación. Como saben, durante toda la sesión existe la posibilidad de hacer preguntas vía chat en el número que tendrán impreso. Yo recogeré las preguntas al final. Óptimamente, si pueden formular las preguntas en inglés, mejor. Si no, yo trataré de traducirlas. Pueden formularlas en castellano o en catalán. Y ya sin más, doy paso a la doctora Rivas, que hará la presentación del doctor Aksu. Cuando quieras, Nuria.
Hola, buenos días. Muchas gracias por hacerme la introducción. Yo quería presentar al doctor Aksu. Es un placer tenerle aquí. El doctor Aksu, como bien has dicho, es el director del Laboratorio de Electrofisiología y profesor asociado de la Universidad de Kocaeli. Él tiene una experiencia y varias publicaciones en el tema de la cardioneuroablación, que es un tema, como tú has dicho, novedoso y que cambia un poquito el concepto de la ablación. Es pasar de la ablación de la taquiarritmia a la ablación de la bradiarritmia refleja. Yo creo que es un concepto muy novedoso y muy interesante y estamos muy expectantes sobre lo que nos va a contar el doctor Aksu. Así que, sin más, le doy paso. Dr. Aksu, thank you very much for accepting our invitation to participate in our conference. I think it's a shame we cannot meet in Barcelona, but at least the technology allows us to hear your conference. I have introduced you to the audience. I have detailed that you have a great experience in cardioneuroablation, and really the important thing is that we are looking forward hearing to you. So, Dr. Aksu, the floor is yours.
Thank you so much. I would like to thank the whole organization committee for their kind invitation, because it's a great honor for me to be together with you in this meeting. And today I will try to present data about cardioneuroablation treatment in different patients group. And I would like to share my screen. I hope you can see now. Actually, today I will try to prepare a presentation for some general cardiologists, and I will briefly discuss the technical details, but as an important point, we should understand the potential candidates for this relatively new treatment strategy. Actually, cardioneuroablation is catheter-based autonomic modulation of intrinsic cardiac nerve system, and as you know that intrinsic cardiac nerve system contains both afferent, parasympathetic, and sympathetic motor neurons, afferent sensor neurons, and local circuit neurons. Actually, according to our theoretical background, the main target of cardioneuroablation is parasympathetic component, but we should remember that actually in intrinsic cardiac nerve system, we see both afferent parasympathetic and sympathetic neuronal fibers. So actually we can ablate sympathetic system as well by using cardioneuroablation strategy. But our main target is the patient with parasympathetic overactivity. Actually, as you know that enhanced parasympathetic tonus or an imbalance between parasympathetic and sympathetic system may cause some different clinical conditions like reflex syncope, carotid sinus syndrome, and vagally mediated atrial fibrillation. But we should remember that in some paroxysmal or even persistent AV block cases, or in some sinus node dysfunction cases, still the main cause might be parasympathetic overactivity. So I think that there might be a common basics for all these different clinical conditions, and I think we can use this definition like polyvagal theory to explain this potential relationship. Actually, to understand which cases should be eligible for cardioneuroablation strategy, we should understand the pathophysiology of vasovagal syncope, AV block, and sinus node dysfunction. As you know that after occurrence of any trigger activity like unpleasant smell, significant pain, or something like that. We see a decrease on left ventricular filling pressure. It increases the sympathetic tone. It will cause forceful ventricular contraction in unmet chambers and stimulate C fibers. After that, we see three different responses. In the first arm, we see a significant bradycardia, then asystole, and then global cerebral hypoperfusion due to parasympathetic overactivity, and which is called as cardioinhibitory type. In the second one, the main cause of global cerebral hypoperfusion is hypertension due to sympathetic withdrawal, and which is called as vasodepressor type. But in great majority of vasovagal syncope cases, we see both sympathetic withdrawal and parasympathetic overactivity, the cause of syncope episodes, which is called as mixed type. So actually, according to our theoretical belief, our main target should be the patient with parasympathetic overactivity or cardioinhibitory type vasovagal syncope cases. But if you can demonstrate the contributory role of parasympathetic overactivity in mixed type cases, cardioablation will also work well in this patient group. As an important point, our potential candidate cases should have recurrent or refractory vasovagal syncope episodes, and we should try conservative and some pharmacology therapies before any invasive treatment option. And as an important point, we should define the contribution of cardioinhibitory component. We can use implantable root recorder or tilt testing for this aim. For example, in this young female, there was almost 40-second asystole episode on implantable rip recorder. She had a lot of syncope episodes without any prodrome, and we got the diagnosis by using implantable rip recorder. But according to our clinical experience and experience of other big groups, you can use heat-up tilt table testing with this indication, and I think that tilt test works very well in this population, so we don't have to use implantable root recorder in all cases. Because the main advantage of tilt testing, you should understand the potential role of both sympathetic and parasympathetic system in vasovagal syncope episodes. For example, in this recently published study, we see some important clues about the occurrence of syncope episodes in mixed type reflex syncope cases. For example, actually at the beginning of the tilt testing, heart rate level is usually between 60 and 80 BPM. Then during tilt testing, we see a stepwise increase on heart rate from, for example, 70 BPM to 110 BPM, and then we see a steep decrease on heart rate during syncope episodes. But as an important point, usually syncope episodes occur in this level. During syncope occurrence, we usually see that heart rate is higher than 60 BPM, because actually the main difference will this step. For example, we should understand that first the heart rate increase to higher level, and then we see a steep decrease, and usually syncope occurs in higher heart rate level. This is why classical pacemakers or even right drop response pacemakers are not effective in great majority of vasovagal syncope cases, because you have to detect the event in earlier steps in here before occurrence of syncope episodes. If you use cardioverter ablation, you should completely eliminate parasympathetic arm, so you will not see any decrease on heart rate. This is another example for mixed response. You can see decrease on heart rate during syncope episodes. You can evaluate vagal tone or sympathetic tone by using tilt testing. This is the main advantage of the technique. Let's check the ESC guideline about reflex syncope cases. According to guideline, firstly, you should discriminate potential contributory role of low blood pressure in syncope episodes. So you should check the vasodepressor or mixed tip responses in the first step. If you see low blood pressure as the main cause of the episodes, you can use fludrocortisone or midodrine treatment, especially in younger cases. If the patient has longer prodromal symptoms before the syncope episodes, you can suggest counter pressure maneuvers or tilt training for these cases. But please remember that in almost 30 or 40% of cases, there are no prodromal symptoms before syncope episodes. According to guideline, if you see a dominant cardio inhibitory response, you can select cardiac pacing in older patients. Why guideline says that? Because there is no randomized control study demonstrating a positive effect of cardiac pacing in patients younger than 40 years old. Please remember this issue. Our all data comes from a little bit older patients, almost 60 years old mean age. What about other bradyarrhythmias? According to ESC guideline, patients considered for antibradycardia pacemaker therapy may be divided as persistent and intermittent bradycardia. And according to ESC guideline, the main cause of persistent bradycardia is structural involvement of sinus node and atrioventricular conduction system in all cases. But in patients with intermittent bradycardia, you should see some paroxysmal AV block or sinus bradycardia episodes due to vagal overactivity, and the guidelines said called this as functional AV block or functional sinus node dysfunction. For example, in this case, we see paroxysmal AV block episodes, and if we see a paroxysmal AV block episode, especially in Holter recordings, we should take care PP and PR interval during AV block episodes and just before AV block episodes. For example, in this patient, during 1-to-1 AV conduction, PP interval is 800 milliseconds. But if you look at here, during a high degree AV block episode, we see a PP prolongation. This is very important. If you see a clear sinus rate slowing during AV block episodes, it should be a functional or vagal overactivity related one. As another important point, you should check PR interval during 1-to-1 AV conduction and before AV block episodes. Like a Wenkebach phenomenon, you should see a PR prolongation in patients with functional AV block cases. For example, during 1-to-1 AV conduction, PR interval is 130 milliseconds, but during just before AV block episode, you see a clear PR prolongation. So these two clues are very important to demonstrate functional AV block. Contrary, PR remains unchanged and sinus rate increases or doesn't change in intrinsic or structural related paroxysmal AV block episodes. If you remember, I said that according to guideline, all persistent AV block are related to intrinsic or structural disease of atrioventricular conduction system. Please look at this ECG. In this case, there was no 1-to-1 AV conduction in any ECG, in any Holter recordings. We see just such an ECG during rest time, and there was also high degree AV block episodes on Holter recordings. And then we basically applied atropine, and if you see that, we achieved 1-to-1 AV conduction after atropine administration. So is this really structural or is this really intrinsic AV block? It's important. For example, in this case, there was significant sinus bradycardia in all ECGs, but after atropine administration, you can see increase on sinus rate. So especially in young cases, we should differentiate real structural AV block or sinus node dysfunction cases by using atropine response test, because it's very easy. You can apply this technique in outpatient clinic visits. It's very easy. Also, you see such a sinus bradycardia and atrial fibrillation episode in some cases, especially in younger cases. And if you see such a response, is significant sinus asystole after AFib episode or just before AFib episode, you should think that this AFib might be related to vagal overactivity. So if you can demonstrate parasympathetic effect in clinical condition, you can treat all these different clinical conditions by using cardioneuralization strategy. But the most important point, after we decided the eligible candidate, we should target this intrinsic cardiac nerve system by using electroanatomical mapping system or by using some different techniques. So before that, we should understand the cardiac neuroanatomy. Actually, the great majority of neurons of the intrinsic cardiac nerve system resides inside some epicardial ganglia area. And we can know, actually, according to our anatomical experiments in human and animal data, we know possible localization of this epicardial ganglia, and we know that the great majority of this epicardial ganglia are located right atrial and left atrial structures. Please look at here that the great majority of these GPs or epicardiac ganglia are located in right atrial and left atrial structures, and then travel the other atrial part to sinus node and atrioventricular nodal system. And by using different techniques, we can map this site in 3D mapping system. If you look at here, you can see macro photograph of the posterior inferior surface of left atrium and left inferior pulmonary vein. And if you look at here, these areas are epicardial ganglia, and these are postsynaptic neuronal fibers from this epicardial ganglia. So if you look at immunohistochemical staining of these areas, these epicardial ganglia areas, yellow color demonstrate parasympathetic neuronal fibers and red color demonstrates sympathetic fibers. So as I mentioned before, in epicardial ganglia, we see both parasympathetic and sympathetic neuronal fibers. So the main issue, how can we detect localization of GPs during electrophysiological study? Different groups use different techniques like high-frequency stimulation, spectral analysis, or empirical anatomic approach, and we are currently using electrogram-guided strategy. Actually, in high-frequency stimulation, if you perform, there are some different settings. It's not important for the present session, but if you apply high-frequency stimulation and in an atrial myocardium site, and if you are in an autonomic innervation site, your HFS application will cause a significant vagal discharge. So you will see sinus bradycardia or AV block in an autonomic innervation site like this. For example, they started to HFS application and it causes significant sinus bradycardia and then asystole. But if you are in a normal atrial myocardium site, your HFS application will not cause any significant effect. So you can differentiate ganglionated plexus sites and normal atrial myocardium sites by using this technique. But as an important point, if you want to use this high-frequency stimulation, you have to touch all different atrial points, and you have to take all positive vagal response sites, and then after ablation, you have to check existence of vagal response in the same area, and it's a very, very time-consuming method. As another important limitation, you will induce atrial fibrillation a lot of times, and you have to perform cardioversion. It may cause a shifting in your 3D mapping system, so it may cause a very prolonged procedures. The other one is spectral analysis. By using a special computer-based software, Pachon et al. Try to define two different atrial myocyte types, and according to this one, they said that in normal atrial myocardium sites, there are high amount of connection between atrial myocytes. So during spectral analysis, you will see such a homogeneous graphic like axion potential curve. But in autonomic innervation site, there are a lot of incursions of the nervous fibers into the myocardium, so it will cause a heterogeneous segmented spectrum and spectral analysis, and you will see fragmented potentials. And we've checked our actually in our first technique we used the combination of high frequency stimulation and spectral analysis of Pachon, and then we checked electrogram characteristics in our targeted areas, and we found that actually we can detect this high-frequency stimulation or spectral potentials by using conventional electrophysiological equipment. And if we target fragmented electrograms demonstrating more than 4 deflections in the region that is consistent with probable localization of GPs, we can achieve a similar success rate, because according to our anatomical knowledge, we know the possible localization of these GPs, because I said that the great majority of epicardial ganglia are located between left atrial and right atrial structures in midline. and there are 2 or 3 minor ganglionated plexus except these ones. So by using fragmented electrograms, we can target or define these potential areas. And we compare this new electrogram guided strategy with the previous one, fast Fourier transform plus high frequency stimulation, and we found that it was similar effect on heart rate variability and syncope burden, but we achieved a shorter procedure and scopy time by using this simple technique. Sorry. I will briefly demonstrate our procedural steps. We have to demonstrate anatomical shell of right atrial and left atrial structures. Again, it is important that the great majority of epicardial ganglia are located in this midline area between right atrial and left atrial structures. So you have to demonstrate this close relationship in all cases. So we mapped both right atrial and left atrial structures in all cases. For right atrial mapping, we use a decopolar catheter. For left atrial mapping, we usually use circular mapping catheter. And we quickly map right atrium and left atrium. Then we check the potential location of phrenic nerve. And then we changed our mapping catheter with a classical open irrigated 3.5 millimeter ablation catheter. And then we changed our bandpass filter from classical 1 to 200 and 500 Hz, and we are trying to find this fragmented electrograms in the right side. You will see some examples for sorry, high amplitude and low amplitude fragmented electrograms. By using this technique, we detected that there are 7 distinct ganglionated plexus cells around atria. The first one is right superior GP, located between anterior wall of right superior pulmonary vein and posterior septal wall of superior vena cava. Please remember that the localization of sinus node, this GP is very close to sinus node, so mainly provides vagal innervation of sinoatrial nodal area. The other one is right inferior GP, located in interatrial septum area. The other one is posterior medial left GP, located between lower part of left atrium and coronary sinus ostium. And if you remember the possible localization of AV node, this GP is important for vagal innervation of AV nodal area. The other one is left superior GP, located between left superior pulmonary vein and left atrial appendage. The other one is Marshall tract GP. If you remember the possible localization of vein of Marshall, this GP see vein of Marshall sites. And the last one is left inferior GP, located in posterior wall of left inferior pulmonary vein. According to animal data and some human autopsy specimen findings, there are another GP in posterior septal wall of superior vena cava between aorta and superior vena cava, and this is called as aorta superior vena cava GP. But we don't routinely ablate this site. I will demonstrate some examples when we have to perform ablation for this GP. And as you see in here, for example, in this area, we are in left superior GP site. You can see the catheter contact point. You can see the fragmented electrograms. Once we start the ablation, we see a significant sinus asystole. Actually, it's the same with high frequency stimulation application. If you are in an autonomic innervation site, your radiofrequency catheter ablation will cause a vagal discharge. So you will usually see positive vagal response in left-sided GP. It's an important point. Complete elimination of electrograms will not be enough in cardio ablation strategy. This is the main difference with other ablations like atrial fibrillation ablation, because these structures are usually located in epicardial area. So if you see a positive vagal response in any site, you have to completely eliminate this positive vagal response after ablation. For example, in this case, we performed 2 ablation points for left superior GP site. We almost completely eliminated electrograms, but during the 3rd attempt, please look at intracardiac electrograms. We see sinus bradycardia, and here we go. We see AV block. So we have to perform another RF application in the same area, and we have to completely eliminate positive vagal response. As an important difference between neuromodulation effect, in left-sided GP, in left superior GP, Marshall tract GP, or left inferior GP side, we usually see positive vagal response with significant sinus bradycardia or asystole or AV block. But in right-sided GP, we only see increase on sinus rate. Please look at here. I will demonstrate some examples. Firstly, you can see the fragmented electrograms. We are in right superior GP side. We are in anterior wall of right superior pulmonary vein. Please look at the heart rate before the ablation, and now we started ablation. This is the first RF point. Please look at heart rate. You see a very steep increase on heart rate. Actually, in almost all cases, we see a similar response in right superior GP side. If we have time at the end of the meeting, we can discuss this difference between left-sided GPs and right-sided GPs, or maybe I can send my answer with via email or something like that after the meeting. I said that aorta superior vena cava GP, we may have to ablate aorta superior vena cava GP in some cases. For example, in this case, we ablated all left atrial GPs, but we couldn't achieve desired heart rate increase. So we targeted aorta superior vena cava GP side. Please look at that. It's a little bit above the right superior GP side. And then during RF ablation on this side, we achieved desired heart rate increase. So just map or ablate this side after failed RF attempt in other well-known GP sites. If you remember this tilt testing recording, after the cardioneal ablation, we checked tilt testing response in all cases, and you can see that there is no vagal overactivity or sympathetic withdrawal after the cardioneal ablation strategy. I would like to demonstrate an example of AV block cases. If you remember this ECG, we demonstrated one-to-one AV conduction after atropine. During 3D mapping of right and left atrial structures, you can see the complete AV block at the beginning of the procedure. So we targeted left superior GP, Marshall tract GP, and then this GP is important for AV node, so we targeted this GP site. We started ablation. You can see intracardiac electrograms. There is still AV block. During RF application, we see some sinus bradycardia episodes, but there is still AV block. We couldn't achieve one-to-one AV conduction. So we went to the right side for the same GP area. Again, there is still AV block. We couldn't achieve one-to-one AV conduction. So the other station was right superior GP. Actually, this GP is usually important for sinus node area, but please look at here. During the first RF attempt in right superior GP site, you see a significant increase on sinus rate in the first step, and then here we go. We achieved one-to-one AV conduction by ablation on right superior GP side. So according to animal experiments, there is a selective innervation for sinoatrial node and atrioventricular node area. But in human, we know that there is a very complicated interconnection between different ganglionated plexus sites. So it's not easy to say the same principles in all human data. What about published data or clinical data about vasovagal syncope? Actually, in 2011, Pachon published their long-term results in patients with vasovagal syncope. These patients are very young, and in great majority of cases, there was cardio-inhibitory type vasovagal syncope. Ratio of mixed tips was 5%, only 5%, and they demonstrated a very, very high syncope-free survival after the cardioneal ablation strategy. This was very promising results. Follow-up time was almost 43 months. in this study. And then Yanyao's team published the largest series about the cardiorenal ablation strategy, and there was total 115 cases, and they demonstrated a similar success rate in vasovagal syncope. But as another important point, in this study, in the great majority of cases, there was mixed vasovagal syncope. This is very surprising, but they also demonstrated that cardiorenal ablation might be attempted in patients with pure vasodepressor syncope, and they demonstrated a similar success rate in pure vasodepressor cases. It was very surprising data. Let's check our data about this technique. We published the second largest series, but in our study, we checked tilt testing results not only before the procedure, but also during follow-up. And we demonstrated 95% syncope-free survival during medium-term follow-up. And as another important point, we check Holter recordings in all cases, and you can see that there was accompanying other bradyarrhythmias in great majority of cases. But as an important point, there was 3 syncope recurrence during follow-up. But once we check the tilt testing result of this case, we see only vasodepressor response. So we started midodrine treatment and followed the cases another 1 year, and we didn't see any syncope recurrence. So I think that cardiorenal ablation should not be attempted in patients with pure vasodepressor syncope, because we didn't see any effect in our follow-up tilt testing results. I think that cardiorenal ablation shouldn't be attempted in vasodepressor type cases. And recently we published the first case control study between cardiorenal ablation and conventional treatment. Actually, this was a retrospective study, case control study, and there was significant difference in number of syncopal episodes before enrollment, because in cardiorenal ablation cases, as you see that syncope burden is very, very high according to conventional treatment arm. And we found that number of syncopal episodes before enrollment is the main predictor for syncope recurrence. If you see more syncope burden, you will see more syncope recurrence during follow-up. We performed propensity matching, and then we found that although in the whole cohort, the pre-enrollment syncope burden was the main predictor for syncope recurrence, cardiorenal ablation significantly decreased syncope recurrence regardless of the pre-enrollment syncope burden. So I can say that regardless of pre-enrollment syncope burden, you can try cardiorenal ablation strategy if you can demonstrate potential role of cardioinhibitory component. And at the end of the study, cardiorenal ablation caused a 77% relative and 36% absolute risk reduction of 4-year syncopal recurrence rate. Let's check our suggestions for vasovagal syncope cases. If tilt test demonstrates vasodepressor response, you should select midodrine or fludrocortisone. There is no clear data for cardiorenal ablation strategy in this patient group. But if you see a mixed type response, you should check midodrine or fludrocortisone response before attempting cardiorenal ablation. After failing of this medication, you can try cardiorenal ablation strategy. What about cardioinhibitory cases? If the patients are older than 60 years old, it's not easy to differentiate structural involvement of sinus node or atrioventricular conduction system. So I suggest cardiac pacing for these cases. But if the patient is younger than 40 years old, there is no other option, because we don't know the real effect of cardiac pacing, and we know that cardiorenal ablation is very effective in this patient population. So I think that it should be the first option in these younger cases. In this group between 40 and 60 years old, you can select both treatment option according to patient and your decision. If you look at here, there is no clinical data studying the effect of cardiorenal ablation in pure AV block cases. But recently published our single center experience in Latin American Heart Rhythm Society as an abstract, and this paper is still in status of under review. I would like to demonstrate that, our procedural steps to select potential candidates for AV block. If the patient has persistent AV block, you should check the atropine response in the first step. But if there is paroxysmal AV block, you should check the Holter characteristics and PP and PR interval change during the episodes. After that, you should demonstrate a normal exercise stress response in all cases. Then you should check the electrophysiological study and you should demonstrate a suprahystian level of AV block. And after all these steps, you can select cardioneuralation if you see positive data. If you look at our single center data about AV block cases, we had 31 patients with AV block. In great majority of cases, there was persistent AV block. In almost 70% of cases, there was persistent AV block. And we have also 3 congenital complete AV block cases. The main indication for cardioneuralation is more than 3-second asystole on Holter recordings. We try to increase junctional rate in these cases. We demonstrated suprahystian level of block in all cases. In 5 patients, we didn't perform biatrial ablation due to high transseptal puncture risk with different indication like intraarterial septal repair or something like that. As you see that in great majority of cases, there was persistent AV block during the procedure. And if you look at the follow-up data, success of cardioneuralation almost 100% in patients with paroxysmal AV block. In persistent AV block cases, AV block free survival was almost 80% at the end of 20-month follow-up period. There is only one study investigating the effect of cardioneuralation in patients with sinus node dysfunction. According to this study, in younger patients, the neuromodulation effect of cardioneuralation seems as durable, but in patients older than 50 years old, you can see a reinnervation after 12 months follow-up period, according to this study. So, as a take-home messages, GPs demonstrate clustering in well-defined anatomical areas. Their localization can be detected by using electrogram guide characteristics, and in well-selected patients with vasovagal syncope, AV block, and sinus node dysfunction, cardioneuralation might be attempted as a first-line strategy. Thanks for your attention.
Thank you very much for this impressive conference, Professor Aksu. It was really great. I want to congratulate you and your team for this excellent work and this excellent research line that you have gone in indeed. It's really very complicated for all not specialized cardiologists to go through these important issues concerning epicardial ganglia and so on. I like very much a picture you have shown about epicardial ganglia location in the heart. It's really amazing. I only have 2 questions. The first is a general question concerning the assessment of the effectiveness of cardioneurablation. I mean, I don't know if syncope recurrence is a good outcome. I didn't see any quality of life or any other measure about quality or other outcomes or patient outcome research that would be important for patients. I don't know, what do you think about this? If we are capturing very well the effectiveness of the intervention only using syncope and other outcomes and not other more patient-driven outcomes such as quality of life and so on. What do you think?
This is a great question, and I totally agree with your concerns. Actually, yes, syncope recurrence is not a perfect tool to demonstrate effectivity of any strategy for vasovagal syncope. Actually, we should also demonstrate potential contribution of placebo effect of a cardioneuralation strategy. If we remember the data of cardiac pacing in this patient population. This is very important because vasovagal syncope has a psychiatric component also. We know that. So I think that we should also check the other life quality of life test or something like that. But before that, we have to perform a sham control study for cardiopulmonary ablation strategy. This is my idea. And we are trying to do that, but it's not easy to get a finding for such a study, get an ethical approval, and it's a little bit hard. But yes, I totally agree with you. We have to do that.
Yeah. You have mentioned a point that is a key issue. The more than probably placebo effect in this kind of interventions, right? And I have a second question. It's more a pragmatical one concerning, you didn't mention, or I didn't notice any mention about complication of the procedure or secondary unexpected adverse events of this procedure is the same as other ablation procedures. Can you please go in that?
Yes, this is another very important question. Actually, in our current approach, we use biatrial ablation. So we can see all possible complications related to transseptal puncture or left atrial ablation. Actually, we don't perform too much ablation in posterior wall, so atrioesophageal fistula not be a big problem during cardiopulmonary ablation. But we can see cardiac perforation, we can see pericardial effusion, we can see some other really serious complications during the cardiopulmonary ablation strategy. So we have to think about that before getting indication. You are right.
That's it. In your experience,
Actually, I didn't see any major complication during cardiopulmonary ablation strategy, but I saw inappropriate sinus tachycardia, almost 7 or 10% of cases. Some of them we fixed the problem. We checked the patients and we taught the patient about the cause of this high rate, and in some cases we used beta blocker treatment.
Okay.
This is the most possible complication.
If no major complications, this is razor enough, of course. Okay, I give the word to Dr. Rivas.
Thank you very much, Dr. Axel. It has been a great conference and have learned a lot. And I have some questions. I think that the first one is about hypotensive syncope, because there are some papers about that, cardioneuroablation and hypotensive syncope. Yeah, I see. I think there's one for WHO. And what's the reason? What do you think it doesn't work in this kind of response?
I don't try cardioneuroablation in any vasodepressive cases, because I don't know what would be the possible explanation for such an effect. Maybe if you remember my first slide about anatomy, we see both parasympathetic and sympathetic motor neurons, but also we see some sensory neurons. Maybe ablation of these sensory neurons prevent reflex arc, afferent arm of reflex arc, and fix the problem with vasodepressor syncope. But according to our follow-up data, we still see vasodepressor response after cardiopulmonary ablation in our cases. So I don't use cardiopulmonary ablation in this patient population.
Okay, and my other question is about predictors of response. I don't know if there is any other kind of predictors that you can use to select the patients, like, I don't know, RR variability or something like that, that we can use to select the proper patient to do this kind of procedure.
Sorry, can you say it again, please? That was a
problem. I was wondering if there is any kind of predictor of response, like to do a Holter monitoring and to evaluate RR variability or another kind of predictors of response to better select our patients.
Actually, the heart rate variability or some other parameters might be better to check your follow-up results, but to select potential candidates, I don't think heart rate variability or other techniques will have any effect, because we don't have any well-known cutoff levels for any vagal activity or sympathetic activity level. But as an important point, we should check atropine response in all cases, not just patient selection. Actually, atropine response will demonstrate our procedural endpoint. For example, in some sinus bradycardia cases, in young cases, I applied atropine and I found that junction rate increased more than sinus rate. So I saw just junction rate after atropine administration. And you shouldn't do cardionervation after such a response, because you will see the same after the cardionervation procedure.
Okay, thank you. I suppose, Dr. Ferreira, there is another question for the audience?
Yeah. We got 3 questions from the audience to Professor Aksu. The first question is comes from Dr. Moya. It was the previous coordinator of the arrhythmics unit of the hospital. And Dr. Moya asks, cardioneural ablation modulates sinus node and AV node persistently, but in vasovagal syncope, we are treating an intermittent disease. What about side effect such as persistent inappropriate sinus tachycardia?
Yes, this is a very, very important question. Actually, we still don't know some possible complications in long term, because our follow-up data is not too much to say something real, and we will see in future our responses. And I think that the ratio of inappropriate sinus tachycardia not too much, and usually lower than 10%, and great majority of this case is not symptomatic. We just check ECG or Holter recordings and say that the patient, your heart rate is a little bit higher than the previous one. But I would like to indicate that the most important problem with the cardionervation and inadvertent increase on sympathetic level after the procedure. But we didn't see such a response like higher ventricular arrhythmia or higher risk related to sympathetic overactivity after our follow-up data, or other groups published their long-term data, and they didn't reported such a complication after cardionervation strategy. But I totally agree with Moya, Dr. Moya.
In any case, is resilient as well. I have a second question from Dr. Sandra Llerena, and she says, question for Dr. Aksu. Given that ablation create lesions on the atrial surface in these young patients, has he seen any tachyarrhythmia development during follow-up?
I think that she asked about any atrial tachycardia or atrial fibrillation. I don't see such a tachycardia during follow-up.
So there is no a secondary adverse effect secondary to the lesions created by ablation in the atria concerning tachyarrhythmias, right? Yeah.
Yes, I haven't seen yet, but it's another possibility for future.
Yes, there's 2 more questions. One from Dr. Francisco. Congratulations for the excellent talk. Is there any patient that you can only target right side ganglia? Is that technically much easier or not?
Actually, this is another important question. I'm trying to keep the procedure in the same in all cases, because we are now trying to get some realistic data for future. But of course, we have to compare different techniques once we clearly demonstrate the clinical efficacy of the cardionervation strategy. As a first step, we should demonstrate clear clinical effect of cardioversion by using a sham control study, and then we can compare different techniques.
That's it. And the last question also from Dr. Moya, he asks is there attenuation of the response at follow-up? I don't know if you have.
Yes, actually, we see a stepwise decrease after, especially after 24 months follow-up period. And we don't know the very long-term data about the strategy. We see a little bit reinnervation during follow-up.
Okay, so we don't have any more questions. I'd like again to congratulate you and your team for this excellent presentation, as all the research line that you got. It's really amazing. I think that it will be very important, as you mentioned before, randomized clinical trial with a SAM procedure in these patients, because the placebo effect, as you said, probably interferes in some way in the results. Maybe also it's important to improve or to go deeper in the outcomes measures in these patients. But anyway, this is a very promising therapy for the future. And I repeat, hopefully next year I would like to invite you again, and if feasible, I would like you to come here to do some procedure of neuroablation in our patients. Thank you very much, Professor Aksu.
Thank you so much. It was a great honor for me. Thank you so much.
Great. Y para el resto de oyentes, simplemente recordar que volveremos el viernes que viene en las sesiones con, en este caso, patología de la neoaorta en pacientes con transposición de grandes vasos reparada con switch arterial, por el doctor Joaquín Rueda, del Servicio de Cardiopatías Congénitas del Adulto del Hospital de la Fe de Valencia. Muchas gracias. Eso es todo.